Dr. John Cox is a cardiologist in Joplin, Missouri, who's affiliated with Freeman Health System, one of the two major hospitals in Joplin. He's an AT Still product from Kirksville. He's a DO who's been in practice for 39 years. He initially started his practice in Columbia and Sedalia, Missouri. He specializes in echocardiography, interventional cardiology, experienced in valvular heart disease, catheterization, cardiac critical care, minimally invasive cardiac surgery, and pacemaker insertion. Dr. Cox is published in multiple journals and is on the board of the Freeman Health System. He's also a professor of internal medicine and cardiology at Kansas City University. He's an interventional cardiologist, and he was the first in the area to perform multiple different cardiac procedures. Again, it's my pleasure to welcome Dr. John Cox to open the KCU 2022 Research Symposium. Dr. Cox, take it away.
Thank you, Dr. Stahlgänger. Well, good morning. I reviewed a number of topics, and I thought that given the fact that I'm kind of the gray beard of the program in Joplin, that I would give you some perspectives on where cardiology has been and some of the major breakthroughs in cardiology that have occurred over the years that have really changed the nature of how we practice medicine. You see my med school graduation picture up there, and then to the right is my son is an interventional cardiologist and I in our cath lab most recently. When I first started my training, the world of medicine was a lot different. Everybody's in private practice. Very few were employed except for in academic institutions. Hospitals were paid basically fee for service. There was no lump sum payments like there are now. And interestingly, Medicare had a payment system where everybody had a different profile. So two people practicing the same specialty in the same town can be paid different things for the same procedure. Obviously paper charts, some of them very thick. And I always had a pocket full of quarters when I was on call because that's how you got hold of the hospital if you were out of your home or on the street somewhere. There was no such thing as cardiac interventions. PTCA was just being invented. There was no such thing as stents. There was no defibrillators or ICDs. And medical therapy for things, very common things, arrhythmias, congestive heart failure, was really in its infancy and not very well done. DOs were, in some areas of the country, considered to be colleagues and certainly well-trained. In other parts of the country, you basically had to prove yourself by out hustling and out working and out thinking your MD colleagues to be considered a person of worth. This is a picture, interestingly, out of a newspaper during the Trump administration when his personal physician was a DO. This is the Kansas City Star saying, is this a real doctor? He was a DO, internal medicine doctor that took care of Mr. Trump. So obviously a lot's changed in regard of having a doctor of osteopathy rather than a doctor of medicine degree. So lots gone on. So let's talk about these different changes. We think about great minds having these huge breakthroughs and you know, movies and other media have kind of hit upon the idea that these eureka moments occur in these great minds and suddenly the world changes. But rarely does that happen. Most often it happens with a lot of hard work, and we'll go into that. So advances in therapy and thought, certainly lots of casual conversations among peers, trial and error. I mean, Edison famously said that he didn't fail, he found thousands of things that didn't work. Happy accidents, I mean, there's certainly a lot of drugs we use today, they're happy accidents. Drug we use commonly for arrhythmias, amiodarone, was originally an anti-anginal medication. You all may have read, Viagra was used for blood pressure initially. There was all kinds of these happy accidents where we find actually better uses for drugs that originally invented for some other purpose. Certainly careful research, publication and peer review are important. You know, we all ran into this through the COVID epidemic of so many people, you know, putting opinion and putting non-randomized things on social media and got jumped on as being real when it was nothing. It was all smoke and mirrors and ineffective therapies. So careful research is certainly a cornerstone of how we make advances. And you publish these in peer-reviewed journals where people can take their shots at you and you can defend yourself. You have these slow incremental improvements that lead then to major breakthroughs. You think outside the box, some new paradigm, but largely, as Newton said, you stand on the shoulders of giants so you can see down the road farther. As you see here, this is me in my younger days here. Cardiologists were once tweedy, bow-tied, stethoscope-wearing individuals who made rounds and made pronouncements about what this murmur did or what this physical exam indicated, but really we didn't have much to do. It was, you know, neurology kind of falls to some extent in that same category where you have lots of pronouncements about what's wrong, but very little therapy. But certainly cardiology was in those days. So what changed things? Well, the EKG was one of the first major breakthroughs. This is William Einthoven. Einthoven's triangle. When you learn about EKGs, you'll learn about that. He was a psychology professor. So here he had no expertise in electrophysiology or even physiology in general, but had an interest. And he used a very large galvanometer, as you can see, a big machine here, and used saline buckets. So he put a hand in each bucket and 1 foot in the bucket and got an EKG of sorts. And this gave him the Nobel Prize in 1903. What did this crude instrument lead to? Initially, it was used for arrhythmias. So you would be able to see what was going on in a single lead. But as EKGs were modified, it became a useful tool for all kinds of things. Cardiac ischemia, other maladies could be diagnosed, hypertrophy by EKG. Early cardiologists went into these little ups and downs and try to correlate these with disease. I had an elderly attending of mine when I was a resident that said, he had a family doctor call him on the phone and said, well, Joe, I just bought my first EKG machine and I wanted to go over this EKG with you on the phone. He said, okay, what do you got there? He said, well, the first bump goes up. So he had, you know, it was really hard to walk a person on the phone through an EKG. There were two physicians. I actually got in an elevator with these two physicians one time at a national meeting, Flowers and Rand, that published a landmark study back in the 60s. And it was such a well-done study. What they did is one was a cardiologist and one was a pathologist. And so they took the patients who died, looked at their EKG antemortem, and then did an autopsy on their heart and correlated EKG findings with autopsy findings and came up with lots of the criteria we use for things like ventricular hypertrophy and infarction locations and things like that. And this landmark study really changed how we look at EKGs. And it was just really a tedious, well-done study by these two physicians. Excuse me. One thing leads to another. When I was still in training, we had rudimentary intracardiac EKGs. So we could put a catheter across the tricuspid valve. Here's the tricuspid valve. We put a catheter across, similar to this one, and we'll record readings from the electrical system in much more detail so we could see the intracavitary P waves, we could see the His bundle, and we could start diagnosing by using these His bundle recordings the nature of why someone had an arrhythmia. These have evolved to not only record what's going on, but to deliver therapy to that area. So you can ablate or destroy the offending area and cure it. So whether you're born with an extra pathway, whether you acquire a scar that's causing an arrhythmia, whether you have intractable rhythm problems that require actually destruction of the electrical conducting system, all can be done intracavitary through these little catheters fed through largely to the thigh. Speaking of feeding things through vessels, cardiac catheterization is the next major breakthrough we're talking about this morning. Werner Forstmann was a urology resident. Now, I'm not sure where he developed his curiosity about what would happen if you put a catheter in the heart, but it was widely taught that if you put a catheter in the heart would fibrillate, you die, and it's a bad thing to do. For some reason, he thought this was nonsense. He took I don't know if this catheter was sterile or not, I have no idea, but a small catheter from where he worked in urology, stuck it in his own left arm, fed this thing up blindly about what he kind of measured about how far it would take to get to the heart, then got up, walked down, thank you, sir, walked down to the x-ray department, took a chest x-ray. As you see, this is the actual photograph up here of the x-ray that he took. He was fired from his residency for his trouble. His attending did not much care for the fact that he did this freelance wild thing, but it opened some eyes that you could actually put a catheter in the heart and people don't die. So next on the list was a pulmonary physiologist, Cornan. And Cornan said, well, this would be handy information to directly measure the pressure. We wouldn't have to guess. So he started experimenting in the dog lab. Richards was the head of his lab, and the two of them developed shaped catheters that allow passage of through the venous system into the pulmonary system and measure pressure directly. They again, through their work and the more work on flow characteristics of the right side of the heart, won the Nobel Prize for their efforts. So now catheterization evolves from that simple little tube up the venous system. Initially, they couldn't get to the left side of the heart. Now, I don't know why they didn't think about feeding a catheter retrograde up to the left through an artery, but they did. They actually punctured the septum of the atrium, a little needle, fed a catheter across the intraatrial septum and measured left heart pressures that way. Ultimately, someone said, well, you know, we could probably do this a lot easier by feeding something backwards through the arterial system, and that's what they did. So they had a retrograde left heart catheterization. Mason Sones was a Navy cardiologist, and he was in the middle of doing an aortogram where he put contrast in the central aorta, and a catheter inadvertently went into a coronary artery ostia as he was injecting dye. Now, fortunately, it wasn't such a large amount of dye that killed the patient. I mean, you're putting contrast in the aorta, you usually put a lot. So he lucked out, had a beautiful view of the coronary artery. And so he said, maybe we can develop catheter shapes that would actually intubate these coronary arteries. The other way, of course, coronary bypass surgery wasn't really a thing, so there really wasn't a need to have coronary angiograms at that time, except, you know, someone with chest pain, you'd be able to diagnose why. The other method was, and I want to walk you through this because this is very strange that they had to go through all this, but they would give a large bolus of acetylcholine, basically stop the heart, pump contrast into the aorta. It would pass, during no cardiac motion at all, passively fill the coronary arteries. And then you give epinephrine, start the heart back up again. This was done there was no such thing as movie x-rays, cine angiography. It was all done with a belt, and you had x-ray film on the belt. One fed it and one reeled it up. You go by and they would do this, they would do this angiography that way. So this was the other way to do a coronary angiogram. Of course, as you can imagine, if you had someone with severe coronary heart disease, stop their heart, some of them didn't wake back up. So this was not a very good method. So Mason Soanes developed the selective coronary angiography. And also another fellow named Judkins took up the idea. Soanes went through the arm, and so his catheters were shaped so that you could intubate the coronaries a little easier from the arm. Judkins went up through the thigh, through the femoral artery, and his catheters were different shape. And the two of them pretty much started the whole idea of selective coronary angiography. And we'll talk about surgery in a minute, but it at least opened the door to be able to do something about coronary heart disease. Dr. Doddert, his idea was to put selectively bigger catheters down the arteries and push some of the plaque out of the way. And Doddert technique was basically a series of larger and larger catheters you were sliding down arteries, largely the peripheral arteries, until Andreas Grenzig in 1977 developed the first balloon that was capable of being used in arteries. One of my attendings in Detroit actually went to train with Grenzig around 1980 when he was beginning to develop this, and was the first cardiologist in Detroit to actually do a balloon angioplasty on a coronary artery. And I happened to be in the room. Obviously I was a trainee, so I wasn't touching the catheters in those days, but I was in the room when that happened. So balloon angioplasty became a thing. And when I first went into practice, that was the only therapeutic tool you had to open up arteries was balloons. And you hope that the balloon created a controlled damage so that it opened up nicely, and you know, not uncommonly, we'd get a nice result. But the problem is not all of them opened up gracefully. Some of them didn't. And they re-narrowed fairly regularly. So in 1992, first stents were invented. They were a little like trying to drive a truck down a narrow alley. They were big and bulky, hard to turn. I was privileged to do the first coronary stent in this city a few years later, about 95. And let me tell you, if you didn't have a straight section of artery to go through, it was not going to go there. We then had to develop therapeutics to keep the stents from clotting, and whole science developed about that. From those catheter-delivered therapies came other things. Aneurysms had to be done through a large abdominal incision, about 6 months of recovery after an abdominal aortic aneurysm repair. So we started using covered stents, cloth-covered stents, Dacron, Gore-Tex, other materials covering these stents, and actually exclude the aneurysm sac. And we started doing aneurysm treatment in that fashion. Drugs were invented to soak into the stents with a polymer and slow down scar formation, so that the stents, which had about a 30% scarring rate, went down to 5% scarring rate with these drugs. And most recently, we can actually replace a valve. And this bottom picture shows a TAVR valve, TAVR. And what we do is we basically inflate a balloon, smash the old valve to the side, deploy a stent embedded with a new valve, all in one step. We've done about 250 of those at Freeman so far. And actually this week is the 20th anniversary of the first TAVR implant. The procedure, if it all goes well, you replace someone's heart valve in about 30 minutes skin to skin if all goes well. So it's a pretty amazing technology, and it's a completely game changer. People have severe aortic stenosis. They can't walk across the room many times, and instantly they're better. It's very gratifying to do that work. Cardiovascular surgery began in the 30s. Robert Gross did a patent ductus arteriosus ligation. That's a connection between the aorta and the pulmonary artery that exists from birth, so that you shunt around your own lungs when you're using mom's oxygenation through the placenta. Sometimes those things don't close and cause extra wear and tear on the heart, extra cardiac output. And so that's a relatively simple thing to do. You just have to tie off this vessel. So put a couple of ligatures on the vessel, no heart-lung machine. And so in 39, they were good enough at getting in and out to do this. However, any more complex stuff that was going on had to be done with the heart motionless. Well, how are you to do that? Someone wake up. So John Gibbon, who was a professor of surgery, invented the membrane oxygenator in his garage. So, if you think about these early things being done, people tinkered in their basements, people tinkered in their garage. And now you see, this is one of our heart surgeons, Dr. Vetch, in his modern operating room. On the table, on the floor down here, you see that is the membrane oxygenator. Keeps patient alive during surgery. This is what's called a cell saver. So you take the suction of blood, run it through a centrifuge, and you can infuse their own blood back to them. So the need for transfusions is much less. But before we got to the modern lab, other developments had to occur. In 1945, if you're interested in this, there's a movie, Alan Rickman plays Dr. Blaylock. And it talks about the development of this. Something the Lord has made, I think it's something similar to that's the name of the movie. Blaylock was a CV surgeon. Helen Tausig was a pediatrician. And they knew that things like tetralogy of Fallot, blue babies occurred. You have other conditions where the right heart doesn't develop, and babies are developing trouble, and they are literally blue. They only live because there's some holes, as you see at the bottom here. This is a picture of tetralogy of Fallot. You see there's a large hole in the ventricular septum that admixes the blood that allows the baby to still have a blood pressure. In the case of tetralogy, you also have what's called pulmonary atresia, or narrowing of the pulmonary outflow tract, along with some shifting of some structures. So these babies had invariably died. So they were trying to find a way to get around this. Well, they tried, they weren't getting anywhere. Vivian Thomas was a high school educated lab tech that they hired off the street, basically, because he had good eye-hand coordination. And Mr. Thomas, with diligent work in a dog lab and good surgical hands that I think he learned largely from Dr. Blaylock, but got to be a very skilled surgeon on his own right, figured out how to do this. And so Dr. Blaylock and Dr. Tausig initially got all the credit. The Blaylock-Tausig shunt, which is a connection between the pulmonary artery and one of the major, in this case, on the left here, it's going to the subclavian. In this case, it's going to brachiocephalic. But at any rate, you're shunting blood directly from the artery into the venous system to allow better circulation of oxygenated blood, and babies live until a point they can have a more definitive surgery. Now it's called the Blaylock-Tausig Thomas shunt, because they finally got around to honoring, as you see, an African-American man who, because of his color, was not given credit for all his accomplishments. And they now have a plaque at Emory University with Mr. Thomas's likeness on it, and he has an honorary doctorate for his work. So shifting gears, heart attack often led to death. And in the early days of hospitals, people were admitted to the wards with a heart attack, given sedatives, pat their hand, mop their brow, let them ride through their infarction. And not a small number of them died suddenly on the wards. Well, Dr. Julian said, no, this is crazy. I mean, we should have these people concentrated so we could do something if something happens. And so he developed the rudimentary CCU. So he put people in the same ward with continuous EKG monitoring, a defibrillator, nurses trained to deal with this and use a defibrillator, and published this data in 1961, and they had a dramatic drop from about 25% to about 10% death associated with acute myocardial infarction. And that's without all the new therapeutics we have now, putting stents in and lysing clots. So this was a major development in cardiology. Drugs also were a major development. As the cartoon says, you swallow potato chips without chewing, they act like little snow plows and clear all the cholesterol of your arteries. I wish it were the case. The three major classes of drugs that really had the most impact on cardiology are beta blockers, ACE inhibitors, statins. Beta blockers are anti-adrenergic agents. They have an effect on blood pressure, heart rate, and stress on the heart. ACE inhibitors affect the renin-angiotensin system and affect blood pressure, fluid retention, and actually mortality associated with heart failure. And statins remove cholesterol through inhibition of production and are the single greatest agents in reducing the chances of another event following a coronary event or stents. These three drugs, beta blockers, ACE inhibitors, and statins, have done more to change the outlook of cardiology than any other classes of drugs invented in cardiology to date. There are also lots of variants of these now. Instead of ACE inhibitors, there are cousins, angiotensin receptor blockers, and other agents that work kind of the same. There are injectable agents that work through monoclonal antibodies to reduce cholesterol without statins use. But this is really the drugs that got the ball rolling and showed unequivocally that they worked. I happened to be a participant in the first beta blocker heart attack trial that was done in Detroit. It was published in 1984, published the data that actually giving beta blockers acutely to slow down the heart rate and blood pressure. This is before we were able to do acute interventions. This is when you still had to ride through heart attacks until patients got better, that the beta blockers made a big difference. So we have a reduction in all-cause mortality after myocardial infarction associated with these drugs, a reduction in hospitalization and deaths with congestive heart failure, better blood pressure control. And what I did not mention also is with the statins, reduce the incidence of future events. Preventive cardiology. Preventive cardiology was not intuitive initially. People were put in bed for 3 weeks of bed rest with a heart attack. It was felt that it was dangerous to move them around until they had a chance for the heart to heal. Kenneth Cooper in Texas coined the term aerobics. And Kenneth Cooper said, the more patients sit, the worse their physiology is going to be. And so he started getting his heart attack patients up and out of bed the next day, which was felt to be blasphemy. People thought he was going to kill people right and left. Well, just the opposite happened. And when I was a trainee, we had a scheduled daily change in their exercise program. They got out into a chair day one, they got to go to the bathroom day two, over a week's time, and they still stayed in the hospital, 7 to 10 days following their infarct with this graduated exercise. Cooper blew this all up, and we realized that the longer patients sit, the worse they do. The people who do rehab will tell you that if you get someone who is elderly, particularly over the age of 80, for 1 day sitting in the bed takes 7 days of recovery. So it's very important that patients get out of bed, start moving around early on, reduce the incidence of stagnation and clots and all kinds of other problems. Diet has gone through a big evolution over the years. It was thought that cholesterol was a culprit, and so cut out the cholesterol in your diet. Well, then we realized, well, that isn't the whole picture. There's saturated fats have an effect. So people say, well, okay, cut out the saturated fat in your diet. Well, then we realized, and then they said, oh, well, let's cut out all fats. And we realized, well, some fats are good fats. They're the monosaturated fats like olive oil are actually good fats. So the most current thinking and the best research is what's called the Mediterranean diet, which is basically a diet that's low in saturated fats, lean protein sources like poultry and fish, lots of fruits and vegetables, olive oil, nuts. Turns out nut oils are also beneficial. And this seems, and there's lots of research to say that this is we finally figured this out. This is the diet that people should be on to reduce cardiovascular risk. There is a direct correlation between elevated blood sugar and cardiac and cerebral vascular events. Diabetes kills people through its effect on arteries. It inflames the arteries. And so if you have a high blood sugar for a period of time, you have a much higher incidence of heart attack and stroke. We have had patients that have had very poor outcomes after things like coronary bypass surgery, simply because their sugar is elevated, and surgeons have learned to turn down patients who have chronic elevation of their blood sugars for long periods of time until that is under control first, reducing surgical risk. So the diabetes control has become a cornerstone of cardiovascular treatment and a very necessary portion of our cardiovascular treatment. Smoking cessation. Around here, we still have 25–30% of the population that smoke, and that's the reason we have 2 big heart programs in town. In a town this size is because we have an extremely unhealthy population. Obesity, poor control of their diabetes, and smoking are the main factors. Smoking cessation is absolutely necessary to promote cardiovascular health, along with reduction in a variety of cancers, most important lung cancer. Hard to do. Nicotine is very addictive, but it's extremely important. And we have realized over the decades how essential it is to stop smoking. You know, back in the 60s, everybody smoked. It's become now much more socially inappropriate thing to do, but there's still not a small number of smokers that exist. And certainly if you go to regions of the United States, particularly the southern states, you know, Kentucky, Tennessee, Arkansas, Missouri, Mississippi, Alabama, Georgia, high incidence of smoking, high incidence of obesity, high incidence of diabetes, and high incidence of cardiovascular events and death. So here it says, it's been a heart attack, take 1 aspirin every day, take it out for a run, take it out to the gym, take it out for a bike ride. So exercise is very important. How much exercise? Well, some is better than none. Back in the early 60s, there was a thing called the Whitehall study, and it was in Britain. Whitehall was a center for government bureaucracy, had a crude elevator and lots of stairs. Turns out the people that rode the elevators died faster than the people who took the stairs, and the Whitehall study proved that definitively. Now you could make an argument that was selection bias. The people that couldn't walk up the stairs took the elevator, but it opened the door to thinking about exercise as a necessary part of being healthy. And so after the Whitehall study, a series of studies, and Dr. Cooper's work with aerobics certainly proved that 30 minutes of exercise 4 or 5 times a week is an essential part of staying healthy as far as cognition, cardiovascular health, mobility, and so many things. Cardiac imaging has evolved a great deal, and the crude sonar that we had in World War II to find submarines led to ability to focus the beam, get pictures that are a little more defined of smaller objects than submarines. And we started seeing the heart for the first time. And the early echocardiograms only showed depth versus time. So you had these little bouncing waves, and as you had this pencil-like probe, and as you move the probe around, you'd get different kind of bouncing waves. And you could tell whether you were looking at the aortic valve, mitral valve, myocardium. And in the early 1980s, actually 2-dimensional echocardiography came into being. And you actually, and I think that my YouTube video is not playing. I tried to play it at home. The person who helped me with these slides said it assured me it worked. But anyway, you basically have a picture of moving myocardium, moving valves, moving objects in the heart in great detail. These have evolved to not only 2-dimensional, but 3-dimensional pictures we've added color, which shows us direction using Doppler, the direction of blood flow. So the colors don't mean anything. We just assign them a color, toward the probe or away from the probe as one way to define which way the blood is flowing. And the speed and velocity of that blood can be measured. We can indirectly measure blood pressure in other parts of the heart. We can diagnose the severity of valvular disease and get lots of information about both systolic and diastolic function of the heart, all from these images now. If I can't see well enough through an endoscope, about as big as your little finger, there is an ultrasound probe attached to it that you can swallow into the esophagus, and the esophagus and heart are right next to each other. We can get far greater detail and better pictures using the transesophageal echocardiogram. Most recently, we now have a miniaturized point where you can go into the vessel. In the lower right-hand corner, you'll see pictures of intravascular ultrasound. You see this little moon-shaped thing here, that's plaque. Various areas, and you can see ABCD on the coronary angiogram. That's where the probe is and telling us where the plaque lies. And we can measure the diameter of the vessel. We can measure the severity of stenosis and the characteristics of the plaque that allow us to gauge therapy. Calcium goes where injury goes in the body. So whether you have a shoulder that's hurt or coronary artery that's full of calcium, full of plaque, calcium deposits there, and the more heavily calcified the plaque is, the more challenging it is to open it up. Just yesterday, I had a challenging case where I had to use a rotor-rooter type device to take some of the calcium off so I could actually deliver a stent successfully. So you know more about what's going on once you take a look. Sometimes you can see the calcium on X-ray. You don't have to put in an intravascular probe. So all this came from sonar. Those of you who are chemistry based know what magnetic resonance is used for. You get chemical signature of compounds, but smart people figured out how to make images out of these signatures so that we now have magnetic resonance imaging. We also have super fast computers, so we can take simultaneously multiple X-rays and get CT images, which are three-dimensional as well. So we now have cardiac and vascular CT images and MR images that give us both, it says non-physiologic, that's a typo, anatomic and physiologic information. We can see actually how fast the blood is flowing. We can give a agent to do a stress test, say, and get MR imaging that would tell us a little about what the image, or whether the heart's getting oxygen or not getting oxygen. As you see some of the examples, this is a coronary CT picture here. MR images are very similar to this. Here's the aortic root, and you see both coronaries coming off the aortic root in short axis view. Here's an outside view. They've turned the vasculature blue for that picture. These images are just getting better and better with each iteration. Each software update we get of our equipment, we get sharper images, and we can do them at a faster time. We can also inject nuclear material, small amounts of material, and pick it up on a imager. This is a technetium-based compound that goes basically where perfusion and oxygen is going to in the heart. So we inject this at baseline. We give them a stress of some kind and inject again, and we can see comparison images. And the lower row is baseline, upper row is stress. And what we'll see is a missing piece in stress that was okay at baseline. And we know that that is getting inadequate oxygenation because the stress caused less of this radionuclide to actually get to the area. So we can use it as a means for diagnosing coronary heart disease. These nuclear images can be also used to check how strong the heart is. Echo is really better for that, but we can get an estimate. So this is a very helpful tool, and it's used quite often as well. Another innovation is pacing or defibrillators. Paul Zoll Those of you who work in medicine know that this company still exists and still makes external defibrillators. That's what, or most of them are on the wards. The defibrillators are made by his company. And he made the first external pacemaker, which basically required some, he tunneled actually the lead under the skin and paced that way, moderately painful, but he was able to demonstrate you could pace the heart externally. Took a while. Anki Sinning in 1958, you see, this is his design here. Also kind of tinkered in his basement with that design, and it's the battery unfortunately lasted only a few months, so you had to have your pacemaker replaced every few months. But these leads were implanted actually directly on the heart. After a time, we developed leads that actually could be threaded through the veins. Most of these are threaded through the subclavian vein. Under X-ray guidance, you can place them where you want to place them. And fortunately, the battery life's a lot better now. It's 10, 12, 14 years, depending on how often you use it. They've miniaturized considerably so that some pacemakers now are about the size of a $50. There's also leadless pacemakers now where we can actually put them through the vein and have little wings that come out and stick in the right ventricle. And so we don't even have to have them connected via wires, reduces the infection rate. Dr. Morawski was a cardiologist, electrophysiologist in Chicago, and he tinkered with a way to defibrillate through using this kind of technology. And the reason this is necessary is that people that have damaged hearts have an incidence of sudden cardiac death that is not small. It's somewhere between 7 and 10% per year. People with a bad ventricle, a weak ventricle, will just drop dead. If you happen to be lucky and you happen to be by someone who can resuscitate you, then you can live. I have patients in my practice who happen to be sitting next to a paramedic and are here today because of that. Most people aren't. They're in their shower, they're asleep, and they just die. And I have patients, families tell me a variety. Well, my uncle's heart just exploded. No, hearts don't explode. They just stop. They fibrillate. And that's most people who die suddenly. This is what happens to them. So Dr. Morawski was an electrophysiologist. In those days, thought, well, what can we do to reduce the risk of sudden cardiac death in these individuals? Medications. Let's try medications. So they'd have a procedure where that you go into the cath lab, put a pacemaker into the ventricle. You pace the ventricle in such a way that it would go into ventricular tachycardia, ventricular fibrillation. And then you give them a drug and you try it again. And if you couldn't do it the second time, you thought, I'm going to reduce this person's incidence of sudden death. Turned out it didn't work. It was thought to work until big studies showed that it really didn't work. It really didn't reduce the incidence of sudden cardiac death at all. So Morawski said, well, if drugs don't work, then we're going to have some means of treating this with a defibrillator. So he tinkered in his basement, and this device you see here is actually a second iteration. We had in Joplin, Missouri, an implant of one of the first generation ICDs on a young man with congenital heart disease who had resuscitation at a swimming pool here in town. And the late Dr. Graham, heart surgeon, used to work in Joplin, and I put in the first of these internal defibrillators with an open chest procedure. So basically a fly swatter type lead on front and back of the heart, tunneled this wire down to the abdomen, and this device was large and was heavy, and this was a skinny 17-year-old kid, so it was a big bulge on his abdomen where this thing was. Luckily, we figured out how to make leads that actually could carry that much energy, and defibrillator leads then became transvenous. And so this device you see in the upper right-hand corner is a picture of the first device I put in this. I did the first one in this town of a transvenous device, and it was still pretty large. It was about this big and had a big lump under their shoulder. But it was certainly a far cry from having to open the chest and sew on these fly swatters and all the things we had to do. So as you see, if you look at the sequential pictures, now we went from 200 cc's plus to 39 cc device. So a marked reduction in weight and size. This required lots of stuff. This required battery technology improvements. It required metallurgy improvements. It required surgical improvements. So that now implantation of defibrillators is a pretty routine thing and recommended to everybody who falls in the category of having a low, it's called ejection fraction or strength of the heart, and who have failed a reasonable attempt at drugs to make it better and have had this condition long enough that we know it's not going to spontaneously improve. So this is a pretty routine procedure to be done these days. So what do we learn from all this? We know that decades of research, contributions from many, many disciplines, hundreds of thousands of people are necessary to make these advances in any field, certainly in cardiology. You've seen the devices that we use in cardiology. This requires multidisciplinary cooperation with people who are extrusion plastic experts or who are metallurgy experts, who are battery experts, who are drug experts to create the devices and the things we can use to actually make this happen. Obviously, a lot of physicians and a lot of scientists put their name on things, but you know, certainly a little humility, you know that this is not yours alone, that a huge amount of effort has to go by to make this happen. The next big step is probably genetics, so that we don't need all these devices. We can just fix somebody's heart or their vessels by a modification of some sort of genetically injected material or even a genetically modified tissue or lab grown tissue that is going to replace a lot of the things we're doing right now. So with that, I'll finish. Any questions?
We have time for questions.
I do.
My name is Ann Owens, so I have a question about the pacemaker.
Okay.
So when the pacemaker is placed in someone, does it irritate them? What happens? How often do you have to take it out and, you know, put a battery or things like that, you know, in the pacemaker?
Well, the device lasts roughly 10 years. At the end of the 10 years, you have to make a cut in the original, over the original device, the generator that creates the brains and battery pack. You remove the old one, unscrew it from the wires, screw it back into the old wires, and then you're finished. It's a quick procedure, generally, you know, 15 to 30 minutes. I mean, sterility is really the thing that takes the most time. You're prepping the patient, putting all your stuff on, make sure the thing doesn't get infected, because if a pacemaker gets infected, unfortunately, it has to come out. There's really no way to re-sterilize it. Does that answer your question?
Yes, thank you. Secondly, we're doing immunology right now. Does the body look at the pacemaker as a foreign thing, or does it, you know, like?
No, the leads are covered with silicones, elastic, and the can is stainless steel, so it's inert to the body. There's no antibody reaction to it. There, you can get some fibrotic reaction, so that around the generator it can sometimes have a calcific, almost an eggshell covering around it, but most often it's just some scar tissue, nothing further.
Thank you very much.
You're welcome. Yes, ma'am. Yes. Non-ferrous metals, basically. Is it, you know, as you know, MRI is magnetic, and if you have something that doesn't react to a magnet, then there's no issue. And so they just change them so that they're all made of non-ferrous metals. It turns out that the alarm over an MRI and a pacemaker is probably more hype than truth. It turns out that they've taken in the dog lab and other means of research and put them into MRI, and actually rarely does anything happen. There's worry about heat formation, worry about destroying the circuitry, but in practical fact, it doesn't happen very often. But you know, you got to be safe. You know, your human lives are involved. So most devices we have now are MRI compatible, with the exception of defibrillators. They haven't been able to get the capacitors to be made with non-ferrous metals yet. So we're still working on that part. Yes, sir.
Are pharmaceuticals keeping up with you?
Are the pharmaceuticals keeping up? Heck, you always want a better drug, right? We want something that's cheap and effective. Yes, I mean, there's certainly lots of innovation that's happening. The problem is largely societal. We in the United States have chosen not to regulate drug prices in any serious way. So you can have drugs that cost $500 a month to patients. I mean, you see that yourself. They can walk across the border to Canada and buy it for $75. Why? It's because their provincial governments negotiate drug prices with companies. And we have actually had legislation saying we cannot negotiate drug prices as a state or federal entity. Ridiculous. And so there's some great drugs out there that just aren't affordable a lot of times. And like I said, I think the next innovation is, you know, we have had these great mRNA vaccines that came out. You know, that kind of thing is going to change how we practice medicine. I think a lot of, in oncology, you're going to have more targeted therapy, and in other fields are probably going to benefit from some of that technology before we do as cardiologists. But.
Question from Kansas City. My name is Baki. Thank you very much, sir, for your presentation. Any kind of thoughts to develop the totally artificial mechanical heart?
Yes, well, there's been many iterations of that. There was a South African doctor the fellow who developed the first heart transplant operation actually worked on a total artificial heart. The problem with them is clotting. And so they haven't quite figured out how to stop that from happening in a totally implanted autonomous heart. Now they do have a left ventricular assist device, which is actually implanted piggyback on the patient's existing heart and takes over substantially the cardiac output. They have to be on permanent anticoagulation. They still have issues with clotting. But the big thing with LVADs is that they have to have an external battery source. There's just not enough energy with current technology to put this fully implantable. So you have the drive line that comes out in between ribs to a battery pack, and driveline infections are certainly a big deal in these patients, and they sometimes cause their death. They can't, you know, it's very hard to keep it sterile forever. So this is about as close as we have come now to an implantable mechanical heart is the LVADs. They're working on it. You know, they're trying to come up with a way to, you know, grow artificial tissue and maybe have a more or less a cyborg type artificial heart, which part of it is tissue, part of it's mechanical. You know, these experiments are ongoing right now. More importantly, I think, is the research to actually repair your heart. If you can find a way to repair damaged heart by some sort of a genetic modification or some way to grow through growth factors and other things to grow new muscle, it would obviate the need to have actually a mechanical heart in that situation. Yes, sir.
I've heard that exercise could lower your resting heart rate to like 60 beats per minute, and that would lead to like better outcomes like over the lifetime. Is it true that a lower resting heart rate is good for health?
Yeah, well, what happens in that situation is that you have more vagal tone. Chronic adrenergic stimulation to the circulation is toxic. And so people who have high adrenergic tone for long periods of time don't do well. People who have damaged hearts have an increase in adrenergic tone. That's the reason we use beta blockade as part of our treatment of heart failure to try to blunt that effect. So it's been well documented that if you can get into a state naturally where you have a high state of vagal control of your heart rate, that you have a better, healthier physiology. So if you look at a study was done in Great Britain probably 15, 20 years ago of British Olympic athletes, and they did monitoring. Commonly, these athletes had heart rates in the 30s at nighttime. So that you're absolutely right. I mean, the physiologic effect of conditioning exercises, one of the things it does is lowers circulating adrenergic tones, circulating epinephrine, and you have more of a vagal, hypervagal state. It also helps extract oxygen from the bloodstream more efficiently as part of what it does as well. So you can take the same amount of cardiac output and have better oxygen extraction after conditioning exercises, just because your muscles are better at removing the oxygen. There was actually a paper came out about 2 weeks ago that said that this is part of the chronic COVID syndrome, is that people have had impaired extraction of oxygen by the muscles as a chronic COVID symptoms reason. I've seen a lot of those people in my practice, and you think, well, it's deconditioning. You check their heart, their heart's working fine. It's got to be deconditioning. It's got to be, or maybe some leftover lung issues from the COVID. Well, it turns out this third factor is present. Yes, they can have myocardial issues. Yes, they can have some lung issues. Yes, they can have some deconditioning. I guess that's a fourth factor. The fourth factor is this muscle extraction. So you improve that by aerobics. Long-winded answer to your short question.
Alma Resendez Chaveras, you have a question? Go ahead.
Pardon?
Yes, hello. I know cardiac ablation can be used to treat AFib and stuff like that, and a loop recorder is usually used afterwards to kind of keep a watch on the heart. But how often do you have to place an ICD on a patient with AFib post-ablation, and considering that they're a little younger than the regular population?
Well, the answer is never, because a automatic cardioverter defibrillator is not used for atrial fibrillation. It's used for ventricular arrhythmias. It's been looked at a way to do atrial defibrillation as a therapy, and it was a failure. And so there are no available atrial defibrillators. You use ablation, you use drugs largely to treat that entity.
Thank you.
Okay, let's all unmute and thank our speaker, Dr. John Cox.